So we're just going to focus on that one.
Okay.
Well, hello everybody. Welcome back to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, and next to me, the amazing and outstanding counterpart in naturopathic medicine, Dr. Jennifer Strong. So Jen is joining us tonight to talk about the impact of diet on how you absorb supplements and gut bacteria and microbiota and a whole bunch of interesting topics like that. So I know recently I chatted with you all about the impact of supplements and in particular ALA. We have a great video up on YouTube now with a whole kind of PowerPoint presentation for it. So what I didn't realize is that just taking the vitamins and supplements is not enough, because taking them is important because you need to get those supplements into you, but how your body absorbs them is very much dependent on the gut and the bacteria in the gut, right?
Yep. Yeah.
So Jen's going to educate us about all that.
Yeah, great. Okay, so today we'll talk about digestion. So many times with patients, we talk about the importance of the nutrients, and then we also need to address how those nutrients are going to get to where they need to go. So with protocols, often the dose is a little bit different for everyone based on what's going on with their diet, lifestyle, and their health needs. A lot of times in visits with patients, we talk about how stress impacts digestion, and we have a lot of aha moments when we realize how much stress impacts digestion. So we'll start from the top and we'll work our way. I always talk about, think about your foods before you before you eat them. And our digestive juices are produced in saliva. Our stomach's also triggered to produce hydrochloric acid. So with digestion, obviously we want some hydrochloric acid to break down our foods. So after we chew our foods at least 20 times per bite, that's the suggested amount to break down the foods properly. It enters our stomach, and that's where the stomach acids are ready to receive it. Stomach acids break down your protein. So for my patients who say, I'll take a protein shake and I'm always gassy after, then we have to talk about stomach acids and how well they're producing acids to break down the proteins. Stomach acid is HCl, so that HCl molecule binds with pepsin to break down the proteins as well in the stomach. And then
This is a terrifying review of medical school for me, by the way. But anyway,
but
keep
there's
going.
so much use for it. So the stomach breaks down all of your foods with the churning action, and then also with the enzymes and acids, and then it leaves your stomach and goes into small intestine, and that's where all the magic happens. So your foods are broken down. The bile mixes, the pancreatic enzymes mix, everything's broken down quite well, and then the nutrients go where they need to go.
Okay.
So let's talk about the sympathetic mode now, so the stress response.
Right.
So stress levels are high, or we're eating in a rush, and we haven't thought about food, we just kind of grab it off the counter, chew it twice, and swallow it. So in that case, stomach acid's not mixing, saliva's not mixing, foods are not broken down. They get into our small intestine and they're not able to be absorbed. And then they get into the large intestine, which is near the end of the track. It's a whole lot of work for the large intestine to break down the foods, and that's when we see a whole lot of gas, bloat, cramping happening, and then poor bowel movements. So that, in summary, is why it's important to chew your foods and to take the time to eat slowly, eat mindfully, think about food, chew it really well.
So what's the right number of times to chew your food?
I say 20.
20.
Yeah, so food goes in, chew 20 times. It does take quite a while. It's amazing though how different your food tastes from the first 2 bites to the last 2 bites. So I always say, like, think about your food and think about how it tastes and how the taste of it changes. You actually have to use your tongue to almost like keep it in your mouth for the first while, because we eat so quickly and so subconsciously that, you know, food goes in, you swallow it, and then it's like, oh, I didn't even chew my food.
So 20 times.
20 times. Yeah.
And then
Tarak should demo it.
we got lots of sushi left over. We probably could. So from the standpoint of the supplements, are there any that are more or less susceptible to the amount of digestion in your food? And do you have to eat, like, do you need to take the supplements with food to get them properly digested, or without food, or how does that all work?
Yeah, so general rule of thumb is vitamins with food, herbals without, because the stomach acids kill or decrease the efficacy of herbals. But vitamins and minerals with food, naturally they're found in foods. So we talk about food because mainly we want to get our nutrients from our foods. So we supplement when we're either not getting enough from foods, or when the need for them is more than what the food will provide.
Okay, so let's break it down for everybody, because I'm sure they're wondering. So vitamin D without?
With.
Vitamin D with food, okay?
Yeah, all vitamins and minerals with.
So your prenatal vitamin, just take it with food?
Yeah.
Basically,
yeah.
Okay. And then if you're doing some of the common ones we use, so inositol, with or without?
With.
Okay. Even though it's not a vitamin, it's just a supplement. But
Yeah,
it's not
a
an
nutrient.
herbal.
Right, yeah.
Okay.
It's not
all
a
right.
plant.
NAC?
With food, yeah, that's an amino acid.
Okay.
That's a
Curcumin?
protein. Yeah, that's a spice that's naturally with food.
So do that one with food
Yeah.
too?
Oh yeah, because that one, it can cause like some stomach irritation on an empty
Yeah,
stomach.
on its own.
Mm-hmm.
CQ10, coenzyme Q10.
Yeah, that's naturally found in like proteins, like meats.
Okay, so again with
food.
food.
Yep.
Okay. ALA, alpha lipoic acid,
Yep.
the new one I started.
Yeah, with food.
With food
All with
too.
food.
So all of these you should eat with your meals.
Yep.
Okay, so which supplements are you commonly telling people to use that they don't need to take with food?
So like chaste tree. So for fertility, it's mainly like if we're not working with meds, sometimes we work with chaste tree, and that would be on its own. That's the only main one for fertility. Teas on their own, like dandelion, mint, ginger.
Do you tell people to use mint and ginger tea for their fertility? As an antioxidant? Is that the
sometimes.
idea?
More for, because sometimes some of the meds can cause a lot of bloat, so the mint and the ginger is nice for as like a curb to help the bloat. Mm-hmm.
Okay.
Yeah,
so just
like all the
obviously the
progesterone
tea on its
juices.
own.
Yeah, kind of like sipping through the day. Mm-hmm.
Mint or ginger tea?
Yep.
To reduce bloating.
Yeah,
Does that work for
lemon balm,
endometriosis
chamomile.
patients? Does it help reduce that kind of
I think
bloating?
you need more than mint.
More than mint, for sure.
Yeah.
Okay, so when I switch to endo patients, I'll frequently add in the curcumin, but for the PCOS patients, it's just the ones we talked about. So that's interesting. Okay, so how about if they're taking, for example, any particular type of diet? So if you have a more sugary diet or a more fatty diet, does that alter the absorption of those nutrients?
More sugary or more fatty diet?
Yeah. Like if I have a bacon cheeseburger, should I be holding off to have my supplements and have it with something healthier?
That's a good
And by the
question.
way, none of you should be having bacon cheeseburgers if you're trying to have a pregnancy, but yeah, what do you think?
Yeah, so I think you're gonna, like, if you commonly get digestive issues from those foods, then yeah, hold off and take it with foods that you digest better.
Okay,
hmm
cool.
But if you can down a burger without any digestive issues, I don't see how it would be a problem with the supplements.
That depends on how much of a rush Tarek and I are in before the show. So, what about antibiotics? What about the patients that, for example, have to take some for whatever reason? Whether, let's say they have a disruption in their, uterine microbiome, so we're giving them antibiotics. So what do we do with those ones?
You mean what nutrients they should take with it? Or?
Well, what should we do in terms of the nutrients or supplements we're giving them if it's around the time of antibiotic use? So should they hold off for a while? It's probably.
Oh, I see what you mean. So
they're probably not going to absorb it.
Probiotics and antibiotics, they're kind of like a dueling action. So
Sure.
usually antibiotics you take away from probiotics.
Yeah.
Which is something tricky if you're antibiotics 3 times a day. So in that case, we just say hold off on the probiotics till you're done the antibiotics. But if you can space it out a good 6 hours, then you can do probiotics and antibiotics separately. Otherwise, nutrient-wise, I think like dairy is an issue with antibiotics. So we say take it away from like your cheese and yogurts and milk.
Do you recommend avoiding the dairy products for the supplements and nutrients as well, as a general rule, or just with the
iron,
antibiotics?
a few of them. So calcium and iron don't absorb well. That's why the Previt has like the AM and the
Right.
PM. Yeah. So some minerals need to be separated, but those are the main ones. Iron's the main one that doesn't do well.
So iron and calcium avoid taking with a dairy product, or around the time of a
iron
dairy product.
away from dairy. Yeah.
Okay.
Yep.
That's interesting because milk and dairy has tons of calcium, but
No, just the iron. The iron away
just
from
the
dairy and
iron.
calcium.
Oh,
Yeah.
okay.
Yeah.
Okay, I gotcha. Oh, so the calcium interferes, you're saying, with the iron absorption. Ah,
Yeah.
I'm sorry. Okay. So it's not that the calcium absorption is altered by the dairy, because it's
No,
chocolate
it's in there.
dairy.
Yeah. Yeah.
Okay,
So chocolate milk and steak, no good?
chocolate milk and steak are probably no good. Yeah.
There goes my
Moses had it right about several
space
thousand
them out.
years ago.
You gotta space them out.
Yeah, no milk and meat together. That's probably why. Anything kind of on the horizon from the naturopathic end of things, or that's newer or we haven't discussed recently? I mean, I know you and I chat every once in a while, but anything new and exciting?
For fertility?
Yeah,
For fertility.
or non-fertility.
I don't think anything that new. We're going to talk about the estrogen relationship with the micro.
Yeah, sure. Go ahead. Chat about that.
Oh, okay.
Yeah.
Okay, so we worked our way down the digestive tract.
Yeah.
Now we're in the large intestine. The large intestine is well populated with gut bacteria.
Okay.
And the interesting thing about the gut bacteria is there's hundreds of different strains. And the diversity of the bacteria has an effect on hormones. So with fertility, we're always, concerned or watching how the estrogen levels are, and with either medications or how your body's naturally producing it. The interesting thing about gut bacteria is some bacteria produce an enzyme called beta-glucuronidase,
Yep.
which deconjugates estrogen. So your body produces estrogen, your liver metabolizes it, your gut bacteria makes it. So when we talk about digestion and the importance of gut bacteria, it's important to recognize the diversity of the gut bacteria so that estrogen can be utilized appropriately.
So this is even if it's their own body's estrogen that's being produced, you're saying?
Yeah.
Interesting.
So some bacteria produce a lot of beta-glucuronidase. Some don't produce much at all. So when we think of our endo patients where estrogen's a huge concern, it's important to keep their gut bacteria balanced so that they're not deconjugating too much estrogen.
So we've been using probiotics in our IVF cycles for quite some time now. And I do think it actually makes a huge difference. And I don't know if you were in the email or not, but we just got our results for the last several months since the start of the year. And we have had the highest success rates I've ever seen.
Wow.
So we're at 80% overall for our IVF program, which we are very proud of.
Nice.
So congrats to my
Yay.
team and the wonderful Dr. Stone who's helped us get there. And yeah, I mean, incredibly high success rates. And those are all, with rare exceptions, single embryo transfers. It's even higher if we have PGTA tested embryos. So we do give people antibiotics at the start, and then we give them the probiotics. I wonder almost if we should reconsider the antibiotics, because maybe we're just kind of messing things up, right? Because we are probably disrupting the gut microbiome during that process. Now most of this is for FET, so less so for the IVF part of things. But I guess that then begs the question: during stimulation for IVF, should we be giving people probiotics? Because I haven't been doing that yet.
Yeah, so is it routine to always give antibiotics for that?
Not for stim,
Not for
only
stim.
for FET, for the frozen embryo transfer. But for the stim part, if you're saying it's really important to keep the gut bacteria uniform or balanced, should we be giving them probiotics while we are in the stim process?
Yeah, well,
I mean, it's harmless, so.
I don't think supplementing with the probiotics is like the only answer. Like it might be more like those patients who have like IBS or like Crohn's colitis or some sort of digestive disruption. Maybe have like a conversation about that and see if it might be an option for those patients.
So then how do I keep this, the average patient's gut bacteria in check? Get them to see you?
Yeah.
So is that mostly
conversation
dietary?
that goes on to figure it out, right?
Yeah.
Yeah.
Is that mostly like dietary changes for those people, or a combination of stress reduction and diet?
Yeah. So like there's a lot of factors that go into good digestion. Like stress is one of them for sure. Like diet's a huge part. Genetics play a huge role. Like if there's family history of digestive concerns. And then like bowel function, how well they're sleeping. Yeah. It might be helpful like for you to have like a little like maybe like 3 or 4 question thing to see if it's worth looking into.
Okay, cool. Yeah. You have to give me a little like
the 3
cheat
questions.
sheet. Yeah, give me a cheat sheet.
Okay,
so as long as I've got, do you have more to talk about on that topic?
No, those are the main ones.
Okay, so as long as I've got you here, I know that you've started doing IV supplement and vitamin therapy. So why don't you tell us a little bit about that?
Sure.
Yeah.
So that was a bit of a long process. So we set up the IV lounge to do IVIT, so intravenous vitamin therapy. So the idea behind that was for our patients, for men and women who are wanting to get their nutrients up really, really quickly. Say they have like an IVF plan or an IUI plan and they've only got like a couple months to get the nutrients in check. IV therapy is a really quick way to do that because we don't have to worry about absorption of nutrients through the digestive tract. Just like we talked about, there's so many factors that are involved in that. With vitamin drips, it's a quick, it's a 1 hour, but it's a quick way to get the nutrients up. So when we do IVs of vitamins, it goes right into the veins. So it bypasses the digestive tract. So all of those digestive concerns that we just talked about are not a concern anymore. It goes right into the veins and then we get the levels up really quickly. So studies show that certain nutrients are important. So for sperm health, like the zinc and selenium are super important for sperm health. For egg quality and endometrial function, vitamin C is super important. So we've got a few different formulas tailored for that.
Yeah, and I kind of brought this up with Jen a while ago because there was a study I came across that suggested that the intrafollicular concentration of vitamin C was directly related to the live birth rate. And so I thought we had the equipment to test for it, and when I chatted with Jen about it, we just decided we would just start giving people IV vitamin therapy so that we could get their levels really high. So this is a fantastic option, especially if you've had struggles or it's been a harder time for you to get pregnant, this may be related to some of the features in terms of your overall well-being and supplement intake and exposures to antioxidants. So if you're chock full of antioxidants, then that'll really help you, because all of us have some degree of oxidative damage in our bodies. And now, actually, there was a conference I was at not too long ago where they actually showed that you can do reductive damage by overdoing it with the vitamins and the supplements. So we're just about to get a new device from a company called Myoxis, which will actually let us measure in sperm and in follicular fluid the amount of oxidative and reductive damage, so we can like actually custom tailor things for them. So even with your vitamin therapy, we'll be able to actually measure the impact on the sperm, which
That would
is
be really
cool.
interesting.
Yeah, yeah, it'll be really neat. Fantastic. Questions for Jen or myself? Are there naturopathic or non-naturopathic questions?
There are.
You got time to hang around for a bit?
Yeah.
Excellent.
Oh, TikTok's interesting. Okay. Okay.
You're gonna have to yell.
Yeah.
Or I'll repeat it.
So this is a comment.
Okay.
This is a comment. Is this an MD and a naturopath working together? Love this.
Sure.
Yes. Yeah. So I kind of interviewed a couple of naturopaths and absolutely fell in love with Dr. Strong here. Strictly platonic, honey. Don't worry, it's all good. And Jen is incredible. She is an extraordinary. We were just talking about this. She's an extraordinarily kind, thoughtful, extremely intelligent, well-versed, very knowledgeable naturopathic doctor who is an amazing complement to what we offer. And I think we've worked very well in harmony, where she is helping to improve the health and well-being of our patients, so that we get those spectacularly high success rates. I personally am one of the kinds of doctors, I guess, that doesn't believe that Western medicine has all the answers. And I do believe that nutrition and stress and even things like acupuncture can be really important. So that's where the amazing Dr. Strong comes in and jumps in there. Yeah.
Thanks.
Yeah, and I think there's a great symbiosis between what you do for our fertility patients and what we do. And I don't think one is necessarily better or stronger than the other. We may need some supplements for Tarek over there. He seems to be choking in the background. But we do work together all the time. Jen actually sees patients here, and she has her own practice. So if you want to contact Jen, do you want to tell people how to get a hold of you? You can either contact us, obviously, and see her through our clinic, or
Yeah, that's exactly it. Yeah.
the best
Call
way.
the clinic.
Okay, so just call us here, 519-944-6400, or you can contact us via email, info@drvictory.com, and just say, I want to consult with Dr. Strong. We should add that to the consult thing on the website
The option?
as an option. You can see me or you can see Dr. Strong. Yeah, there you go. We never thought of that.
It's taken over your website.
Yeah. And we have a whole page dedicated to Dr. Strong on our website as well. So if you need information, check that out. And very soon we'll have a blog, so we'll get you on there to do some blogging for us. So that's an easy way to reach us.
Which probiotic would you recommend?
Ooh, okay. So, just like in general, so we talked about like digestive concerns today. So there's a lot of options, but if we're talking about just general health probiotics, then the lactobacillus blends are good. So there's a couple strains of lactobacillus and a couple strains of bifidobacteria that kind of cover most of what the gram-positive bacteria is required for good gut health. However, there's also probiotic suppositories. That's what you were talking about earlier, right? So
Vaginal suppositories, you mean?
probiotic vaginal suppositories.
Yeah.
Which have a little bit of, they're still lactobacillus, but they're a bit of different strains that are more appropriate for the vaginal canal and the endometrium. So it kind of depends on what's going on. There's other strains that are more specific for like for those who, just got off a big round of antibiotics and kind of flushed out all their gut flora, there's a few specific strains that are helpful for that. And then if there's other health concerns like digestive related, there's specific strains for that too. But generally, like the lacto and the bifo are best.
Are there any particular brands that you think are better than the others?
Yeah, so there's a few brands that I like, and I'm not affiliate. I don't get any endorsements from anyone.
Yeah.
Nor
do I.
Nobody does here, you know.
No, I know.
No, we're like
We really should.
we can't. I can't even recommend a particular brand.
I'll take the.
I got yelled at on our YouTube video for guys about why I didn't recommend a specific brand. I literally can't. It's against our college guidelines. But go ahead.
But I will say in Canada does a really good job at regulating health products. So probiotics are, because they're supplements, they have to have an NPN number, which means they've been third-party tested for like what's on the label is actually in the bottle, and then for like any contamination too. So I only recommend like Canadian
Certified.
products. Yeah.
Okay, and I know you use a lot of NFH.
Yes.
Do they have a probiotic that you like in particular?
Yeah. Yeah, so they have one called ProBio SAP. It's got 11 different strains in it. So
Okay.
mostly the lacto and the bifo, and then I think there's another couple.
And that's a
in there
good
too.
oral.
Oral, yeah.
Okay,
And then they also
vaginal?
have the vaginal strains too, which we kind of panicked last week when they were on back order.
Right, that's the flora. Okay,
Yeah.
which we use all the time.
Yeah.
Yeah. So if I want to order the oral one, I should be ordering what's it called again?
ProBio. However,
ProBio
it is
SAP.
it's a professional line, so you have to order it through a pharmacy or a naturopath.
So
but
you'd order it.
or the pharmacy.
Oh, the pharmacy. Okay.
Yeah. Or there's a lot of good ones like similar like lacto and bifo that like regular companies make too. The tricky thing is though with probiotics, like there's the strain and the species, and then there's a number after it, and that's what is specifically studied in clinical trials. So that's why we use the professional lines, because they look at those trials and they use the strain, species, and number exactly how the
Oh,
clinical
from the
trials
trials.
work. So
Okay.
probiotics are a little tricky.
Excellent.
Yeah.
Excellent.
If a person has SIBO,
Mhm.
then probiotics can upset tummy.
Yeah, so SIBO is small intestine bacterial overgrowth. So we see that a lot in men or women who have a motility disorder. So instead of like the intestines going through peristalsis, like squeeze, relax, there's an overgrowth of bacteria because it's just sitting, it's not moving a whole lot. So gut bacteria should be in the large intestine, not the small intestine, and with SIBO, you've got it in the small intestine. So because there is either an overpopulation of bacteria or the wrong strains of bacteria, or it's the right bacteria in the wrong spot, you have to be really careful with how you supplement probiotics. So there's usually some steps you take in treatment before you supplement for SIBO.
Okay, so
Probiotics.
what are some symptoms of SIBO?
They're very vague. So gas, bloat, heartburn, indigestion, bowel changes like constipation, diarrhea.
What's the treatment for that?
So we usually do antimicrobials first
Okay.
to lower the population of gut bacteria, and then you work on motility.
Okay.
So like carminatives or
What's a carminative?
carminatives are like herbs that like decrease spasm. So like the ginger, ginger, cinnamon, fennel, cardamom help with digestion because they support peristalsis.
Okay.
How often would you suggest to do acupuncture before an FET next month? Booked to see Jen Friday.
Ooh. Okay, so the protocols we use for FET.
I'm gonna leave you for 1 second because Tarek's dying. Something back there.
The protocols we use for FET for acupuncture here is usually once a week leading up to the transfer, and then within 3 days before and after the transfer. So that's ideal. The the trials that were done, or like the protocols that we use, were from studies where it was done 3 months leading up to an FET. But I know that's not always possible for everyone, so we just kind of start where they're at and aim for weekly for that 3 months.
Okay. A lot of questions. Hi, Dr. Jen, Dr. V. We do IV therapy in our clinic in the US. What are your thoughts on IV, NAD, and glutathione?
Oh, okay. So this person's talking about intravenous treatments of NAD and glutathione. Glutathione is something that we're considering starting here soon. I think it's great for fertility. It's helpful for both men and women. The NAD I'm not as familiar with. I know that's on my list of things to learn, but definitely glutathione's a good one. The IV therapy in the U.S. is a little bit different from what's allowed in Ontario. We've got some quite strict guidelines to follow.
Okay. Thank you.
You're welcome. We were about to lose Tarek, so I had to go get him some fluid rejuvenation.
I had a late miscarriage last month, April 13th. It was my second pregnancy, and I had a miscarriage at 19 weeks. Still, I have light bleeding. It's almost 4 weeks. Is it normal?
Oh, I mean, if you were 19 weeks pregnant when you had the miscarriage, yeah, I mean, anywhere from about 4 to 6 weeks of bleeding would be normal. However, in a 19-week loss, frequently there can be placenta which is retained. So if you're worried, you definitely need to follow up with your doctor to get an ultrasound to make sure that there is no retained tissue, because that can really generate a lot of infection and potentially some harm and scarring and damage to your uterus. So make sure that you get checked out if you're concerned, for sure.
Hey doc, could you explain your modified natural cycle protocol in detail versus letrozole protocol? Sylvius plate, do you trigger in both protocols? Also, would you add PIO in a natural cycle for endo?
Okay, so we don't do a lot of modified natural cycle. We do mostly letrozole. But I can tell you the differences. So we use Lupron, which has been clinically proven to be beneficial. There's a meta-analysis on it as well, which shows that it increases your success rates. Then we give our patients some letrozole, and we wait until their lining is triple layer. If we have to, we give you a minimal amount of estrogen just to thicken the lining. But typically most people will do fairly well with just the letrozole. And then we wait till your follicle's about 18, and then we give you vaginal and injectable progesterone. If you have endo, studies show that a higher dose of progesterone is appropriate. So we do aim for those higher doses, and we do measure the progesterone levels to make sure we're at the right dose for that. In a modified natural protocol, what you're doing is essentially skipping the letrozole and the Lupron. You allow the patient's egg to grow. When it gets to somewhere between 17 to 20 millimeters, most places will trigger the release of the egg with HCG, and then they aim for doing the embryo transfer 7 days later. The main issue with that is that it's a little more unregulated and a little harder to manage. And there is some evidence that HCG has an apoptotic effect on eggs. So I've tried to avoid it. I'm not really sure what the benefit of doing the HCG is. So we try to avoid doing the HCG. We've done it from time to time, but I'm not sure that it actually makes much of a difference or has a significant benefit. And we definitely rarely use it with the letrozole protocol, because by the time the follicle is large enough, we can just start your progesterone. You don't need to trigger the egg. And it's a little bit easier for balancing out the progesterone levels, because if you naturally release your egg, your corpus luteum function starts to increase the progesterone just as you've started giving the patient progesterone. So you have to initially titrate down the amount that you're giving them while their level is going up. And then when their level starts to plateau and fall back down, you got to start giving them more again. So it's a lot more work to keep that adjusted properly than it is to just skip the release of the egg and go right into PIO, which often will prevent the egg from releasing, and then it's a lot easier to manage.
Can I do a folic acid IV?
Can you do a folic acid IV is the question.
So folic acid binds to everything, so we actually don't even put it in our IVs.
Oh, because it'll
Yeah.
bind to all the other
Yeah, it
molecules.
yeah.
There you go.
So the ones you hear, so there's the minerals, so zinc, copper, selenium, chromium, and then the vitamin C, and all the Bs except B12 and folate.
Are we doing vitamin D IV? No,
No, just water soluble.
just
vitamins.
water
Yeah.
soluble. Okay, not the
Yeah,
fat
and then
soluble
hopefully
ones.
glutathione soon.
Oh, cool.
Yeah.
All right.
Mm.
Very good.
I'm dead. Okay. What kind of probiotics do you recommend for IVF? Vaginal, floral, probiotic, or the one for digestive?
So with my patients, we usually go through kind of the digestion discussion that we just had. If there's concerns with digestion, either like they're not getting enough nutrients from their foods or they're having symptoms of digestion, then we'll talk about supplementing with a probiotic. I don't know if it's the best idea for absolutely everyone to take, because again, we want diversity in the gut flora. But when there is a concern, then usually like the lacto and the bifo strains orally is a good idea. Vaginally, part of like the IVF protocols here, they do a vaginal probiotic, which is the Flora, the NFH Flora one, which I do think is a good idea, because there's a lot that disrupts the pH and the flora of the vaginal canal and the endometrium.
Yeah, so we definitely have good evidence that supports the idea that the uterine and vaginal microbiome are very important for your success rate. So we do address that by making sure our patients are taking a probiotic vaginally. And then for many of our patients who are doing the testing, and we use the company Fertility for that, but for many of our patients that are using the testing and finding out that they have either a vaginal or a uterine overgrowth of specific bacteria that are not favorable, or if they have an underdeveloped lactobacillus population, we use oral and vaginal probiotics to restore it after we're done, because it's actually relatively difficult to get bacteria into the uterus. And there is data from a company called iGenomics that showed that there is a significant difference between what is in the vagina and what is in the uterus. Now, the stuff I've been seeing from Fertility actually seems to be fairly similar, although the concentrations are different. So you might have a higher concentration in the vagina, lower in the uterus, or vice versa, but it's typically the same strains that are there. So initially, based on the iGenomics data, the concern was if they just took a vaginal probiotic and what's in the vagina doesn't reflect what's in the uterus, maybe it wasn't getting across. So that's why we started using both the oral and the vaginal, and it does seem to work really well. I have had one patient, notably, who herself was a naturopath, who had significant uterine microbiome that was out of whack, so what we call dysbiosis. And rather than take antibiotics, she actually took a whole naturopathic approach to things, which was recommended to her by someone in the Toronto area, I think. And she actually cleared very effectively her uterine infection with the probiotics and the supplements and things she was taking, which was fascinating, because when we do it,
you have to give them weeks of antibiotics, which then disrupts everything else that's going on. So we've actually now started flushing antibiotics into the uterus to kill it locally, so it's not getting into the gut and getting into everything else, which hopefully will result in an even better outcome. So
Another cool trick with vaginal probiotics is sometimes the bugs get resistant to antibiotics.
sure.
And boric acid has been quite helpful with like with BV, bacterial vaginosis and candidiasis. So sometimes doing a treatment with boric acid and then the probiotics helps kill the bad bugs and repopulate the good ones.
That's part of what she used
Yeah.
actually. It
Yeah,
was
yeah.
boric. So how long do you treat them with boric acid for?
2 weeks.
2 weeks.
Yeah.
Vaginal boric acid treatment.
Suppositories, yeah.
Suppositories.
Mhm.
And what's that, once a day?
Yeah.
Okay.
Mm.
Cool.
Yeah.
Very, very good.
Hi, Jen and Dr. V. I'm gone.
Tarek's out of the
Jen's
picture.
in.
Well, you are
I'm-
dying in the
I'm
background.
clearly dying.
Her cough is going on. And I think this is now dead again too.
No. That's there's a whole
That's
thing
good.
going on.
There's a whole thing going
There's a
on.
whole thing
I
going
don't
on.
need to worry about it.
Yeah, I took care of it.
Okay.
Hi, Jen, Dr. V. Do you need the 8 to 12 weeks of IV therapy in order to have an effect on egg and sperm?
The IVIT?
Yeah.
Or-
Yeah, they're
Yeah.
talking about your stuff. Yeah.
Yeah. No, I don't do it like weekly no. We do it like once a month.
For how
The
many
IV.
months?
Well, again, it depends, but in general, like I would say like 3 is good. Like, so sticking to the 12 weeks before, start 12 weeks before and then once a month.
Yeah. So I think
Treatments.
that's what they
Is
were
that what-
asking.
oh, okay.
They were saying 8 to 12 weeks for IV vitamin
Therapy
therapy.
to-
Yeah.
Oh,
So
yeah.
So,
So
about
once
8
a
to
month,
12.
not weekly, yeah.
Okay.
Mhm.
Okay.
Yeah.
So once a month for 2 to 3 months.
Yeah.
Okay.
Yeah, and then we try to get it done. So when we're talking about IVF, have them done a couple weeks before an actual transfer.
Okay.
Yeah.
Very cool. Very cool.
Dr. V, if
That's
we are patients of yours, is it another fee to see Dr. Strong?
It is another fee. It's not
Mhm.
included in what we do. Now, if you have, well, I'll let Jen answer this, but if you have insurance, Dr. Strong does have insurance covered patients. And if not, then they can pay privately as well. Do you want to
Yep.
chat about that?
Yeah, so I'm licensed to practice in Ontario, so if you have coverage for naturopathic medicine through your extended healthcare, it would apply for like consult visits and for acupuncture. And IVs, actually.
Oh, really? Even
yeah.
the IV vitamin therapy?
Yeah.
Oh, cool.
Yeah.
There you go.
Mhm.
And if it's private, how much is it for your
So
consult?
first visit is 200. IVs are 225. Follow-up visits and acupuncture are 80.
Not bad at all.
Mhm.
Cool. There you go.
For those who have endometrioma, what would be your transfer protocol?
So endo protocols are complicated. If you have an endometrioma, we need to have a lengthy discussion about whether or not it's prudent to remove the endometrioma and any endometriosis that's there, because that's a lot of inflammation. So I will have a discussion about the benefits versus the risks of surgical removal of your endometriosis and the endometrioma. So following that, the best protocol that we are using and that I strongly believe in because it's very evidence-based. So 3 months of Lupron and letrozole, then a letrozole-based FET protocol, and then high-dose progesterone. And for Canadians, you're looking for a level around 150. For the Americans, it's around 45. And we do use the supplements that there is pretty significant evidence for. So NAC, curcumin, coenzyme Q10, resveratrol, and alpha lipoic acid. Those are the 5. So we use all of those. I think there's some evidence for another one called bromelain. Does that sound right? Have you heard of that one?
Yep.
And so that can also be used, but I don't want to give people overkill with all the supplements. So we've been slowly adding on. It took me a while to get to resveratrol, and now alpha lipoic acid does look very, very potent. Make sure you check out that video. Tarek put the link right up there where my finger is pointing right now in the final video. So yeah, check that out. And there's a great video on alpha lipoic acid on our YouTube channel. So check that out, along with some other videos we've done with Dr. Strong in the past, including our Which Prenatal is Best video called The Good, the Bad, and the Prenatal. So yeah, that's our protocol for frozen embryo transfer. You want to minimize estrogen exposure. So if you can avoid being exposed to estrogen, that's the best thing for you.
Hi, Dr. V&T. Hey, see.
There, you're back, baby. Yeah, way to go.
What is lean PCOS or phenotype D PCOS?
So lean PCOS is a little bit on the margin of what we normally see for PCOS patients. So there's really kind of two categories of PCOS patients. People have lately been trying to come up with 3 and 4, but really essentially there's two categories. There is kind of the traditional PCOS where they struggle with weight gain, acne, hair loss, hair growth in places where you don't want it, and irregular periods. And most of those patients tend to struggle with their weight and are over their ideal body mass index. And then you get the lean PCO where they're kind of the opposite. They don't have a lot of symptoms usually, and they're very, very lean. They're almost kind of abnormally thin often, and they'll have less insulin resistance, although they can also still have insulin resistance, but typically a lot less than the patients that are in the more traditional category of PCOS. It's about 10% lean and about 90% not lean.
Hello, Dr. V. I had my 6th embryo transfer this week, did a double embryo transfer, and one of them got retained in the catheter.
Oh yeah.
And we immediately retransferred. How does this affect outcomes?
So there's actually a lot of studies on retained embryos. So first of all, I would argue this should almost never happen if they've loaded your embryos properly. But if it does happen, there are studies that have shown that there is a decrease in success, and there's actually studies that have shown that there is not a decrease in success. So the only thing that probably is very wise to do is if one of them went in and the other one did not, I would not let your catheter go all the way up to where it did the first time, because you could actually physically damage the first embryo. So you don't want to be going in quite as far. But the big problem with that whole event is that the embryo has now left its nice oxygenated, perfectly gas neutral, temperature controlled environment. It jumped into a catheter with way less of everything in it. It went across some distance, usually at least 10 feet or so, from where it was being loaded to getting into the uterus. Then it's going back into the lab, being flushed out, looked at under the microscope, and then it has to be reloaded again. So there's a lot of exposure to different temperatures, different gas concentrations. Embryos don't like being yo-yos or going on roller coaster rides. So inevitably there is going to be some degree of compromise. If you've got a really strong embryo, it'll probably handle it well. If you've got a weaker embryo, I don't think that that's going to be an ideal outcome for sure.
So a lot of questions.
What time is it? I don't have my watch on me tonight.
50.
Oh wow! All right. Well, we'll keep Jen as long as we can, but don't. I know you have family, so don't hesitate to say you got to go.
For Dr. Strong.
Okay.
Very specific
Yes.
question here. What do you think about the autoimmune protocol diet to reduce inflammation prior to an embryo transfer recurrent loss patient with endo?
I think if there's an
I'm glad she got that one.
As I read it, I said, you know what?
Yeah, it's all hers.
That's for you.
is it so autoimmune protocol meaning diet?
Yeah.
Okay. Yeah. So if there's some concerns with autoimmune conditions like outside of fertility that's affecting fertility, I think it's a great idea. So autoimmune protocol is avoiding foods that can be difficult to digest or absorb. So it's making the digestive tract super easy to absorb the nutrients it's getting. So typically autoimmune diets are gluten-free, dairy-free, soy-free, corn-free, no alcohol, no caffeine. They're pretty, you can still get a whole lot of nutrients from them. They're nutrient dense, but they do require a whole lot more work and prep to stick to it. So I think it's a great idea for those who are struggling with immune issues to begin with. So if there is like Hashimoto's or celiacs or whatever it is, I think it's a great idea for just like someone to try out of not having an autoimmune issue. I don't see the value of it aside from what like the Mediterranean diet could offer.
And part of that question was, if they have endo, do you recommend an
Yep.
autoimmune diet?
So if the endo's not managed by other means, I think it's a good idea.
Should it be done together, or you don't think it's as important? So if I'm doing my endo protocol, should they also be doing the autoimmune diet?
Like your supplements?
My supplements and my Lupron and my Letrozole and my high dose progesterone and all the things we do on our end.
Yeah.
Should we also tell them to stay on this kind of
Autoimmune.
autoimmune diet? Yeah.
Yes. So if they're still struggling with symptoms of endo, then yes.
Then do it?
Yeah.
Okay, cool.
Yeah.
Very good.
What dosage of alpha lipid acid recommended before FET, and are there many different ALA on the market? Is there anything specific we should look out for, I imagine?
Do you want to take that one, or do you want me to?
You did your hour presentation.
So the studies I looked at said 600 to 800 milligrams once per day. That seems to be a very reasonable dose. That was both for men and for women, and it can be used in both. There are specific studies looking at IVF, including live birth outcomes, which is why I've become like a real diehard believer in alpha lipoic acid. And they also have sub-studies of populations for women with PCOS, women with endo, male factor problems, all of that. So it does look like it's a very potent supplement to be used. In terms of different specific, like manufacturers or distributors, when I looked it up, I Googled it, and there were like 5 million different manufacturers for ALA. So I know that NFH makes one, and like everything from NFH, it's always called SAP, so I think it's ALA SAP.
Yeah.
So I don't recommend one product over another because we're not allowed to, but it's convenient for us to recommend that one because our pharmacy carried it. So I just went to them and said, do you have it there? And they said yes. And I said, which brand do you carry? And they said, we have the NFH. So I said, great, we're already recommending some of their products, so we may as well just stick to it. But I don't necessarily believe that one version of ALA is better or worse than any other. I don't know if you have an opinion on that. Are there particular brands of ALA that are better?
I think it's more the dose. Like ALA has to be dosed like high. Like I think there's like 375, so like 2 a day is pretty typical. ALA is one of the ones, there's like the L form and the R form, but again, like you can take either and it'll adjust when you absorb it anyway, so I don't see a need.
I just want you to know that I had an organic chemistry seizure when you said the L form and the R form. That little rapid blinking action, that was me having like a university nightmare all over again.
How much is high dose progesterone?
Yeah, so as I mentioned earlier, you're looking for, in US units, which is nanograms per mil, you're looking for a level of 45. And in the Canadian units, which is nanomoles per liter, we're usually looking for about 150. That's the conversion. So that's high dose progesterone. Typically speaking, in US units, in someone without endo, you're aiming for somewhere between 10 and 30, and in Canadian units, that's 40 to 100.
Can you talk about mosaic embryos when they are used and how successful for live birth?
You
Thanks.
want to tackle that one,
Nope,
Jen?
Heart you guys.
Well, we love you too. Okay, so we have a video on mosaic embryos on YouTube, so please watch the YouTube video. However, the current data suggests that, well, let me explain what it is. So a mosaic embryo means that when they biopsied the embryo, there were 2 or more populations of cells. Some of them were completely normal, meaning 46 balanced chromosomes, and some of them were not normal, meaning they were either missing a piece of, or missing a whole part of, or a whole chromosome, or they had an additional part of, or a whole additional chromosome. So if you have less than 50% of the cells having the abnormality, in most centers that's considered a low-level mosaic, and if you have more than 50%, it's considered a high-level mosaic. So the current evidence suggests that if you're dealing with a low-level mosaic embryo, the chances of success are equivalent to what you would get from a euploid or genetically normal embryo. However, that is 50%. So if you're going to a center that's getting kind of a typical success rate for a good clinic, which would be about 50%, you'll probably get that same 50% success rate using your low-level mosaic embryo. I can't say that we've done enough transfers with low-level mosaics because we actually don't get very many of them. But the reality is that with our success rates being as high as they are right now, I don't know that that would hold true, because if it's only 50% and we're getting 85 or higher with a euploid, I would be very reluctant to call those two the same. So in a low-level mosaic, if it's all you've got, should you transfer it? I think you need to talk to your doctor. You probably should talk to a geneticist, and then you got to look at your finances and your resources and your willingness to go through more cycles, and then make a decision that's right for you. If it's a high-level mosaic, the data I've seen, including now 2 presentations from the world expert on mosaic embryos, the recommendation is don't bother. Your chances are around 0.7% that it'll turn into a normal baby. So that's a lot of money to get a less than 1% chance of success. So we wouldn't really advocate for that. But again, it's a personal decision, and that's something you got to review with your doctor and with genetics and see. Most centers are going to be unwilling to even attempt it. We're a little bit more flexible because we believe in patient autonomy, but you know, you'd have to kind of get it through our ethics committee, and then they'd have to agree, and if they said yes, then yeah, we would let you do it.
30 versus 90 days of HGH priming, is one more effective than the other? Dr. Vic.
Wow, we definitely don't do 90. That would be astronomical in terms of cost. We actually don't even do 30, we just do 2 weeks. I don't think you need to use a lot of HGH, and there are a large number of studies with zero uniformity in their protocols or approaches. So I don't believe that you need to go remortgage your house just to supplement with human growth hormone. It doesn't make sense. I'm probably pretty opposed to that. Yeah, we do it 2 weeks before the stim, and then in through the stim. So it's probably a total of 30 days, but we're not doing it for 30 days prior to the stimulation.
It's 9 o'clock. Almost. Yeah, 1 minute ago.
Are there 5,000 questions left?
I'll be honest.
Are they Jen and Rahi questions, or are they mostly Rahi questions? Because I don't want to keep Jen longer than she signed on for.
How long do you want to?
Wow, we're kind of diehard, so we'll stay another 15 minutes if we need to.
Okay, let's let me see the Jen questions. Let me pull them out real quick. Give me a minute here. Okay, should endo patients look for probiotics that don't increase histamines, or is that unrelated?
Wow.
Yeah, I don't know if, so the thing with probiotics is, I don't know if you can do that, like if you can focus on gut bacteria that doesn't produce histamines, because it depends on, I don't know if they really classify those ones. If you can find that information, that might be helpful, but I haven't come across any.
So there are antihistamine protocols for IVF because
Mhm.
people believe that there is this rumor out there that that's like another kind of immune modulating protocol. I actually looked up evidence for this. There is none. So I was not able to find anything that suggested that using an H1 or H2 blockade actually improves the outcomes. So I'm not convinced about that. We are going to do a study of doing an H1 blockade, so that's a proton pump inhibitor, to see if it improves the chances of success at frozen embryo transfer, because having nothing to do with histamines whatsoever, there is some evidence that suggests it relaxes the uterus, and if we can get your uterus to stop contracting at the time of embryo transfer, and we can get the embryo to just sit there and instead of trying to surf out on the contractile wave, it might give it a better chance of sticking. So we're in the process of putting together that study, but I don't know that the antihistamine thing actually works. And I certainly don't know
I
any
think
evidence
that's
about probiotics and histamine. I'm glad they asked you the tough
I
questions.
know.
I'll be honest, I can't answer any of them.
Any of them, yeah. I
Can't
can't
answer
answer
any of
any of them either. That's right. That's why we have Jen.
Yes.
Yeah.
Dr. Strong,
Mhm.
what dosage of vitamin C IV drip is recommended?
Ooh, so we use 10 grams here. 10 grams in
Whoa.
one IV, yep. Yeah, and then we balance it out with some minerals, so it's not so acidic. So yeah, that's ours. I've heard of a whole lot more, and then I've heard of less, along with some other things in it too. So
Am I allowed to ask a question
yeah.
related to vitamin C?
Yeah.
You've never asked a question
Because-
before. This is a show first.
When I usually feel slightly sick,
Yeah.
I go to Costco. I buy that 1,000 milligram
Yeah.
vitamin C with,
Yeah.
it's got that other stuff in it. What's it called?
Flavonoids?
I don't know. It's got something in it.
Yeah.
Anyways, when I feel a little bit sick, I take 2 of them.
Okay.
That's the equivalent of 2,000.
That's 2 grams.
That's 2 grams.
Right.
Yes.
So
So
you're
here's the
doing-
thing. So vitamin C has an awful time being absorbed. So I usually say anything, if you dose, it depends on what you need. So if you're sick, you need lots. You're going to absorb more when you're sick. When you're not sick, you don't absorb a whole lot. So if you're going to take vitamin C when you're not sick, 250 milligrams is probably all you're going to absorb at once, if that. So the 1,000 milligram capsules or tablets are usually time release, so they've got a little bit of calcium in there, so that it's not all absorbed at once, because it's water soluble. If you take it without the time release, you're just going to pee out majority of it. With IVs, you bypass the digestive tract, so again, there's no digestive concerns, so what you absorb through an IV is going to be a whole lot more than what you absorb orally.
Okay,
So when
well,
you take it orally,
Yeah.
when you take it orally, high doses, often it'll cause diarrhea, because it absorbs fluids, right? It's water soluble, so it's going to absorb more fluids into your gut, and it's going to cause diarrhea.
Okay, wild question.
Yeah.
So I start feeling sick.
Yeah.
I run in here and you fire in 10 grams of IV vitamin C.
Oh, you're
Will it,
running.
will it,
You're
will it
amazing.
prevent me getting sick?
Yeah, so it supports like white blood cell production to fight infections, and it reduces like the inflammatory response to an infection.
So is there actually
So-
data on IV vitamin therapy for people getting sick?
For prevention, I don't know about, 'cause I only
Like
know more of the
acute
fertility
treatment.
stuff. But I don't know, like,
We put you on the spot on this show.
I know.
So you better be ready.
Jen will get us
You're
an
like, prep my
answer and we will let
questions.
you know on the next episode. Yeah.
I do know that, so we don't do this here, but I do know there's a lot of like hangover IVs where when people
Yes.
are quite sick and dehydrated from too much drinking, the IVs are amazing for that.
Which none of you should be doing
No.
because alcohol is terrible for you.
Yeah.
It's a class 1 carcinogen and it's wretched for your sperm and for your eggs. So please, no drinking. Yeah, 0.
You'll edit that part out.
Yeah, 0 drinking. No hangover IVs available at Victory Reproductive Care.
Repurposing of it all.
Yeah.
Yeah.
We're gonna have a lineup every week if people find out. Yeah, I need Jen. You look very confused.
I read the name as part of the question, but it wasn't.
Okay.
There was an underscore. Because I can't really get in here, you know. Is uterine PRP during suppression with Lupron okay leading up to an FET?
Yeah. So listen, I love uterine PRP. I do believe in the studies that support the use of uterine PRP. They're pretty convincing. Can you do it with Lupron? Yes, you can. But it's done 2 days before the embryo transfers. So it's not going to interfere much. And by that time, most of the Lupron effect should have worn off if you took it at the right time and you have an average cycle.
Is 400 mcg of folate adequate? Healthy diet and eats lots of greens. This prenatal doesn't make me sick, but want to make sure I'm getting enough.
So Health Canada says 400, and so I usually think of it as for those who are in really good health and fertility is not a huge concern, and they just need like the minimum. 400 does the trick. For those who have been trying for a while and there's some concerns, I usually up it. So folate deficiency or folic acid deficiency can be one of the causes of infertility. So 400 micrograms might not be cutting it. Studies show up to 5 grams a day is helpful for fertility support. So again, everyone's different, but depends on like absorption rates, dietary sources, how well they're able to absorb it. There is an MTHFR gene deficiency that sometimes we see. So sometimes the folic acid isn't absorbed well. We have to switch to the methylfolate form instead to up the folate levels.
Which I learned from you and I now use, so thank you.
Yeah.
Yeah.
When you're priming with DHEA,
Yeah.
is it possible that it can cause high interfollicular testosterone? If it did, would that affect egg development or quality?
Well, that's what the whole point of it is to provide substrate to produce estrogen, because the testosterone gets converted to estrogen and you're basically giving it the building blocks to make the estrogen molecule. So that's the whole point of it. The question probably should be, can you overdo it? And the answer is, I'm not aware of any studies that show that you can. I had a whole bunch of patients that said, oh, my physician in the US started checking my DHEA levels and said they were too high. None of the studies that looked at DHEA ever measured the DHEA levels. So I don't think that that's a valid, consideration.
This is a good one.
Okay. What time is it?
9:08.
Okay, 7 more minutes. Are you good?
Yeah.
Okay.
Hey, Dr. V or Dr. S,
Okay.
for either one of you guys.
Challenge.
Why is it?
Do we have to hit the buzzer or something?
You know what? Let's see it. Let's see it.
Yeah.
Hey, Dr. V or Dr. S,
Okay.
why is it that ERA studies have been shown not to be effective? And the second part of that question, is it based on just the timing or when you start your progesterone?
I think that's a new
Obviously
question. Yeah. Okay, so ERA is the endometrial receptivity array. There are multiple different studies now, 7, which have shown that not only is it not useful, including their own study that they ran, but actually the most recent study, which just came out Friday, is a reanalysis of their data. And in that study, it actually shows that if you properly calculate the data they presented, it was actually detrimental to do the ERA. So the ERA test is very much based on the gene profile of the tissue in the uterus as it relates to the duration of exposure to progesterone. So in other words, what they're really looking at is, does the gene profile of the uterus look quote unquote receptive after a standard 5 days of progesterone? And if not, then do you need to go longer so that the gene profile in theory will become what it's supposed to become, or shorter because you've already overdone it? And the answer to all that is nobody knows what the heck's going to happen to your gene profile, whether you're exposed to shorter or longer progesterone, number one. And number two, the test just doesn't work. It is proven not to work. And I knew this years ago because I was an early adopter and started using it for loads of people. And when I noticed it wasn't working, I asked for them to explain why it wasn't working. And so they provided me with a study which very clearly showed no benefit. And they said, well, it's a trend, and it wasn't even a trend. So at that point, I knew this was not the real deal, and we basically stopped doing it. Now, I will tell you that there is a very rare circumstance in which I still use it. It's probably less than once a year, maybe once every 18 months now, where we get someone that has a very thin endometrium, and no matter what I do, I can't get it to thicken. And I just want to know if it's receptive or not receptive. I don't care if they say pre-receptive, post-receptive, because I think that's nonsense. I just want to know receptive or non-receptive. And so I think it may be useful in that regard in very, very, very rare circumstances, but otherwise it's useless. Interestingly, I had a private conversation with a very well-known fertility specialist who shall remain nameless, who said to me the other day that they use it all the time. And yeah, Tarek, you know this individual well too.
Yeah.
And I said, yeah, but it doesn't work. And they said, no, we think it makes, a huge difference. And so I actually sent that individual the new study which shows that it doesn't work, because it doesn't work. I mean, it's categorically being proven not to work. So don't bother with the ERA test. It actually is likely detrimental. It's very expensive. And if you need more evidence that it doesn't work, the rumor mill was that the individual that designed it actually committed fraud with the data, was subsequently kicked out of the company, and the company that owned it has spun off the product to another company because they knew it was going to be going into all sorts of problems.
Hi, Jen, Dr. V, and T.
You've been included. We're like a family now.
I couldn't not ask this question.
Yeah.
Why does Clomid bring forward ovulation in a patient who ovulates late, like on CD 1822?
I'm assuming you want me to take that. So the way Clomid works is it fools your brain into thinking that you are not producing enough estrogen. So your brain sends out a stronger signal, and because the signal is stronger, your ovaries respond a little bit harder and faster. So it speeds up the process typically. It's kind of a simple way to explain it, but that's it. Last question, dude. Are we at 9:15?
We're at 9:13.
Okay, last question.
Okay. Is it okay? Like I said, I'm dying here. Is it okay to tan or go to a tanning bed during IVF, egg donations, or pregnancy in general?
I don't suggest it. I think if it's like a one-off, say like you're going to a wedding and you just like need one, I don't think it's going to do a whole lot of damage. But there could be some potential concerns with damage if you're going repetitively. So answer no, don't go.
Yeah, so that was a very moderate, gentle response. I'm going to give you a classic Dr. Victory response, which is, oh, hell no. Yeah, no. I mean, that's a lot of heat. It's a lot of UV exposure. It's all the chemicals that they put on, and none of those are good for you when you're going through fertility treatment. So I don't even let my patients use hair dye, let alone go to a tanning bed. So yeah, no, that's not happening. Done? We will take your additional questions, guys, and between Jen and I, maybe we'll get together and blow out some videos for you. Are there like a million? Can you screenshot a couple? Even after the fact, it'll be okay. All right, well, that was a very long fertility factor fiction. Thank you for Dr. Strong joining us, as always, amazing. If you guys want Dr. Strong to be back on the show, can you throw up some love? So show us some thumbs up or some hearts or whatever it is on whatever program you're on. And if so, we will bring her back again. It's actually being too long. We used to do it more often. So Jen should be on with us again. And we will be happy to take any of your questions. If you do want to see Dr. Strong, you can see her right here. So just contact info@drvictory.com or call the clinic, and we will add in a special toggle on our ask for a consultation so you can see Dr. Strong if you want, instead of seeing me or see both. So we can make all of that available for you. We hope you guys have all the success in the world in your journeys, and we will see you again next week on Fertility Factor Fiction. Thanks,
All right,
Jen.
thanks
Love
for
you.
having me.
Yeah, good having you here again. Take care, guys. Have a good night.